Okay, so good afternoon, everyone. Thanks again, or thank you for joining us today for the Kirby Institute seminar series. This seminar today is part of the Global Health series. If for those of you who don't know me, my name is Susana Vajneri. I'm an associate professor at the Global Health program, where I lead the Neglected Tropical Diseases Research Group. And I'd like to begin by acknowledging the traditional custodians of the lands on which we gather today and pay my respects to their elders past and present. In my case, I'd like to acknowledge the Bedigal people. I also would like to extend that respect to Aboriginal and Torres Strait Islander peoples who may be joining us today. I think you're probably all familiar with the way these online seminars work. So just a few housekeeping reminders. I'll introduce Brendan, and then he will give his presentation. That will be followed by questions and answers at the end. There's only one way for you to communicate with us today, and that's going to be through by clicking on the Q&A icon that you can see at the bottom of the screen. So please, feel free to interact and type questions either during the session or at the end. I would then now like to introduce Brendan Lee, who is or was maybe a PhD student in the NTD research group in the Global Health program. He recently submitted his PhD thesis that includes 4 papers. 3 of them are already published, and 2 of them actually in quite prestigious medical journals that you may be familiar with, the Lancet Global Health and the Lancet Regional Health Western Pacific. I would like to say a few more words about Brendan. Well, mainly to say that it was a pleasure to supervise him through his PhD since 2020. I'm sure you'll see during the presentation that we will mention his publications that they attest, or his work attests, for his competency and hard work and dedication. But also it was really a very pleasant and experience to have him, even though now he deserted academia and is now joining us as a senior program evaluation role in New South Wales Health. Just a few more words. So Brendan joined the NTD research group with the aim, or one of his interests was actually to conduct research in low and middle income countries. But unfortunately, COVID started at the same time that Brendan started his PhD. So he was not able to directly travel to the settings where his research took place. But making use of his excellent communication and coordination skills, Brendan was able to continue existing collaborations and relationships in those countries in order to continue data collection and successfully conclude his PhD research. So now I'll hand over to Brendan, who is going to talk about his research that aimed to evaluate the role of ivermectin-based preventive chemotherapy in improving the control of soil-transmitted helminths and scabies.
Hi, thank you so much for that really kind introduction, Susanna. I'm just going to go share my screen. All right, as Susanna has mentioned, my name is Brandon. I am or was a PhD candidate working at the Global Health program in the Kirby Institute, working under the supervision of Associate Professor Susanna Vajneri, who you just met, also Professor John Caldor, Dr. Naomi Clark. Now, I spent the last 3.5 years studying intestinal worm infections and scabies, and I had a particular interest in really understanding the impact of ivermectin preventive chemotherapy in improving the control of these 2 diseases. And throughout this presentation, I will unpack a lot about what that means, because I'm cognizant of the fact that some people don't have past experience or exposure to NTD research. First, I'd just like to acknowledge the Gadigal people of the Eora Nation, who are the traditional custodians of the land on which I'm standing on, and I'd like to pay my respects to both their elders past and present. So here's what I have coming up. I have First, little NTD 101. So just a bit of background on neglected tropical diseases. And then I want to introduce this idea of preventive chemotherapy, which underpins all of the research that I'll be presenting. And then I want to talk a little bit about ivermectin as well, which is an anti-parasitic drug. Then on the right, number two, I'll be talking about the findings of four of my research studies that was included as part of my PhD thesis. And then after that, we'll jump into the conclusions and future directions. So, neglected tropical diseases, NTDs for short. What are they? They are a diverse group of 20 diseases endemic in subtropical and tropical regions of the world, usually parasitic, usually infectious, but not always. They are recognized as a major global health problem. Most recent estimates from 2017 have estimated that we have a global prevalence of over 1 billion people for all NTDs collectively, contributing to over 62 million disability adjusted life or dailies per year. They contribute devastatingly to debilitating impairments in both physical and cognitive development, malnutrition, blindness, social stigma, physical disabilities. The list goes on and on. And as a result of these impairments, the entities perpetuate the cycle of poverty and disease by impairing an individual's ability to function productively in society. And they are quite neglected because they systematically affect marginalized populations and have received, at least historically, very little funding and research attention. Now, here on the right, I have a number of the NTDs. And you might be familiar with, or at least seen pictures or heard of some of these NTDs. So one of them on the left here is lymphatic filariasis. This is colloquially known, this disease is colloquially known as elephantitis, and it's a type of NTD that is caused by parasitic roundworms that affects the lymph nodes and lymph vessels. On the right, we have an NTD called onchocerciasis, colloquially known as river blindness, and that's another NTD which can cause blindness through repeated bites of the black fly vector. Now, ivermectin does work against these diseases, but that is not the focus of my presentation today. Today, I really want to focus on these two NTDs. On the left, there is scabies, which is a skin condition caused by parasitic mites. And on the right is soil-transmitted helminths. I use the term STH for short. And these are just type group of intestinal worms. I should also say that there's a graphic warning on the next slide. It's a video of a colonoscopy demonstrating infection with one of the worms. And I'm aware that it's lunchtime, so if any of you are eating and have a queasy stomach, I would suggest turning away just for a minute or two. So STHs, a group of intestinal parasitic worms, like I said. On the left there, I have the Latin names of each of the 6 species. So we have Ascaris lymphocoides, Tracheus trachea, 3 different types of hookworms, and Strongylitis stercoralis. And I've included this video that I found on YouTube. It's a colonoscopy demonstrating infection with species. And I've included it because I think to me, it really brings the disease to life and it really shows you what we're talking about. So I'm going to play this video now. So you can see there that this is the Ascaris worm in the intestinal tract of an infected patient. This is quite a long worm. It's probably measures a few centimeters, and you can see it slithering around the intestinal tract. Yeah, so it's a pretty nasty and bad disease. Now, a lot of us at Kirby are epidemiologists, so I know we're very keen in understanding the global epidemiology of different diseases. So this is data from 2014. Data is somewhat old, and I have to say things have improved since then. But I think the overall message from this figure really stays the same, in that it's STHs are a serious global health problem. You can see it affecting a lot of South American countries, a lot of countries in Africa, as well as being quite predominant in the Asia-Pacific region. Now, from our most recent estimates in 2017, this is from the Global Burden of Disease study published by Lancet, it was estimated that the global prevalence of STHs was close to 900 million people, contributing to almost 2 million dailies per annum. Now, this is quite a shocking and astounding amount. All right, so let's move on to scabies. So that was a bit of STHs. Let's talk a little bit about scabies. Scabies is a contagious skin condition. It's caused by the parasitic human itch mite, the name of the particular species I have on there. And I'll just play this video. This is just a video of a scabies mite under a microscope. And what this mite does is it digs under your skin and it deposits eggs under your skin. That causes an immune reaction, and that immune reaction causes quite intense itching and scratching. And as a result, scabies has been linked to quite substantial reductions in quality of life due to the social stigma, as well as difficulty sleeping. So you can imagine if you're intensely scratching all the time, it can be very challenging to sleep. Now you might be thinking, okay, this might, cause itching. So what are the health risks? So if this is left untreated, it can be a pretty dangerous condition. Scratching can promote bacterial infections, opportunistic bacterial infections, by enabling bacterial pathogens to enter the bloodstream through skin breaches. And this results in secondary complications such as impetigo, which is a superficial bacterial skin infection, invasive bacterial infections, rheumatic heart fever, rheumatic heart disease, and so on. And on the right here, I have a really handy figure from Daniel Engelman showing the complications of scabies. So scabies starts at the top here, impetigo, and then through the skin breaches, it allows different bacterial pathogens to enter the bloodstream, causing a whole host of medical conditions with various case rates as shown on the bottom of the figure here. In terms of the global epidemiology of scabies, globally, there isn't a lot of data. This is largely due to the fact that scabies wasn't designated as an NTD until 2017. So we had long underestimated its public health importance. But from the surveys that we have completed, we know that it's a major issue in a lot of remote Aboriginal communities in Australia and many countries in the Pacific region here. You can see that Daniel zoomed in on a few of the countries. The studies I'll be talking about today take place in Timor-Leste and Solomon Islands. You can see that scabies are pretty bad public health issues there. There are also parts of Africa and South America that are endemic as well. And again, this is from the 2017 GBD study. Global scabies prevalence close to 200 million, contributing 4.5 million dailies per annum. Again, these are just astounding figures. All right, so that's sort of NTDs/STHs/scabies 101. Now I really want to introduce this concept of what we call preventive chemotherapy, as it underpins all of the research I'll be presenting. So preventive chemotherapy, or PC for short, is the large-scale administration of safe and efficacious drugs to risk groups. And I'd like to show you what I mean by this. So say this population of stick figures, these blue and yellow stick figures, say they represent a population of people, with the yellow figures being at higher risk of contracting a disease or having greater risk of morbidity compared to the blue figures. Now, the blue figures are just ordinary people. Now, I'm using the example of STHs, say STHs are endemic in this population. So that means many of the yellow figures will have the infection, some of the blue figures as well. Now, if you want to control this disease at the population level, either to reduce the prevalence or reduce the morbidity associated with the infection, what we can do is we can go out to communities and deliver safe and efficacious medicines to everyone. And this would be without any prior diagnosis and regardless of the infection status of the individual. And this is exactly what many ministries of health in low and middle income settings do. They employ this public health strategy for diseases such as lymphatic filariasis and onchocerciasis. These are diseases that you saw 2 pictures of earlier. And this strategy is called mass drug administration. You can also think of it as community-wide PC. Different labels for the same thing. Now, let's say we have the same population again. Another strategy is to target only those at higher risk of contracting disease or developing morbidity from it. This is called targeted preventive chemotherapy, and it actually informs the principal control strategy recommended by the WHO for STH control, where the drugs albendazole or mebendazole, these are benzimidazole and thelomycin, is recommended to be delivered to school-aged children only, given that there is some evidence to suggest that they are at higher risk of morbidity. So the good thing about PC is that it allows us to achieve very rapid and substantial reductions in NTD burden. And there are currently 5 NTDs that rely on some type of PC strategy for control. These are STHs and scabies, the 2 I'll be presenting on today, onchocerciasis and lymphatic filariasis, the 2 that you saw a picture of, as well as trachoma and schistosomiasis, which I haven't talked about yet. And the pharmaceutical agents to be used in PC programs to control these NTDs include a few different drugs: ivermectin, albendazole, praziquantel, azithromycin, and diethylcarbamazine citrates. Now, of these 5 drugs, I want to focus on ivermectin because that's what I've been studying for the last few years. So you may have heard of ivermectin. There was a lot of controversy around its use in COVID. So ivermectin is a broad-spectrum antiparasitic agent. It has very excellent safety profile in young children, in everyone except for young children and pregnant women. Although there is some observational evidence suggesting that it may be safe in young children, but we're not too sure yet. It has been used in very, very successful MDA programs, like I said, for onchocerciasis and lymphatic filariasis for the last 30 years. Onchocerciasis, they use ivermectin alone. Lymphatic filariasis uses ivermectin and albendazole and diethylcarbamazine citrate. Now, on its own, as a monotherapy regimen, has really excellent efficacy against scabies, at least when we use it as 2 doses. And this is an important point that I'll get back to later. And has somewhat moderate efficacy against some of the STH species. Now, when you use it in combination with albendazole, it has excellent efficacy against all STH species. So, like I said, preventive chemotherapy using ivermectin, either alone or with other drugs, may be an effective way to control STHs and scabies simultaneously. On the left here, I have some of the information for scabies. So, as I said, we know that MDA with 2 doses of oral ivermectin is increasingly being used to control scabies, particularly in the Pacific region. However, with MDA, using 2 doses significantly increases the drugs and implementation costs, especially when you're rolling this out to thousands or hundreds of thousands or millions of people. There is some evidence that suggests 1 dose of ivermectin MDA might just be as effective, and this is one of the hypotheses I test in one of my studies that I'll get to. On the right, we have STHs. Like I said earlier, the mainstay of its control is school-based targeted PC using the drugs albendazole or mebendazole delivered to school-aged children. However, these drugs have limited efficacy against 2 really major species. That's Trichuris trichura, Strongylitis degradans. And for the STH side of things, I'll be largely focusing on these 2 species, principally for this reason. As I said, ivermectin either alone or in combination with albendazole might address this gap. So the thing is, given that we know that ivermectin is highly efficacious, either alone or in combination with other drugs, against onchocerciasis and lymphatic filariasis, if we show that it can be effective in controlling scabies and STHs, that would really be like killing 4 birds with 1 stone, resulting in a more efficient control strategy and significant cost savings associated with implementing PC. So that brings me to my thesis aims. The overarching aim of my thesis was to generate evidence to support the inclusion of ivermectin-based PC in integrated NTD control programs, with a particular focus on STHs and scabies in the Solomon Islands and Timor-Leste. And to do that, we need to do 2 things. The first thing is we need to characterize the epidemiology of STH and scabies in these settings to really define the public health need for ivermectin-based PC. After we do that, we can implement various interventions using ivermectin and evaluate its effectiveness in controlling STHs and scabies at the population level. And this is really what my thesis was about. Now let's shift gears a little bit. Let's get to the fun stuff. Some studies. So interestingly, this was actually the last study I conducted. But I would like to present it here first because I think it gives you a really good overview of the effectiveness of ivermectin PC or STHs. And this paper is a systematic review and meta-analysis looking at the effectiveness of ivermectin MDA in controlling STHs in endemic populations. And this paper is currently under review at Infectious Diseases of Poverty. Now, this is quite I don't know if you can see the numbers, but this is just a flowchart of the systematic review process. So you can see on top, we started with nearly 5,000 studies, and after filtering and sifting through all of these, this was a lot of work. We ended up with 15 papers that we included in the meta-analysis, and I'll present the meta-analysis findings now. So first up, we're looking at the effectiveness of ivermectin PC alone, so without any other drugs, just ivermectin by itself, against this species of STHs. This is Strongyloides stercoralis. Now, because ivermectin is not used in STH control programs specifically, most of the studies were studies that investigated the impact of lymphatic filariasis or onchocerciasis control programs, which do use ivermectin, on off-target STHs. So all of these 7 studies included in this meta-analysis were MDA studies, mass drug administration, as opposed to school-based targeted PC. So we have 7 studies, and after you crunch the numbers, we find that the pooled prevalence reduction is 81%. So an 81% reduction from baseline to follow-up. Now, the WHO recommended drug to be used in STH control programs, albendazole or mebendazole, almost no activity against strongylitis. Even with clinical studies showing that multiple dosage regimens of albendazole resulting in a cure rate of only 20-30% max. So here we see with ivermectin, in line with the clinical efficacy literature with testing ivermectin, that the pooled prevalence reduction in PC programs is 81%. So that's quite a sizable reduction for this species. And this is a very challenging species to control. Okay, so next. So this graph is looking at the effectiveness of ivermectin PC alone, so no other drugs, against Trichuris trichura. This was our other species of interest. You can see here that there were 5 studies included in this meta-analysis, and we found a prevalence reduction of 50%, which is a modest reduction. But it does mean that there will be some collateral impacts of lymphatic filariasis and onchocerciasis programs, MDA programs, on this species. And you need to remember that with this species, the WHO recommended drug, albendazole, doesn't work really well for this species. So it's good news to see that ivermectin does somewhat reduce the prevalence of this species. But what I think is even cooler is that when we combine ivermectin and albendazole for the same species, Trichuris, we see a really large reduction. And granted, there were only 3 studies in this meta-analysis, but we see that the effect size are quite consistent across those 3 studies. And when you combine those 3 studies, we get a pooled prevalence reduction of 89%. And this is particularly important because, like I have said many times, albendazole alone has low efficacy against this species. Okay, so that was the systematic review and meta-analysis. I hope that gives you a really bird's eye view of the impact of these interventions on STHs. Now I want to shift gears a little bit, take a step back. One of the aims of my thesis was to characterize the epidemiology of STHs to define the public health need for ivermectin. And this study does exactly that in the context of Western province of Solomon Islands. And this paper has been published in the PLOS NTDs, I believe it was in 2020 or 2021. You can see here that this is our lovely fieldwork team, very instrumental in the study's success, traveling between villages to collect data. And this is Erica and Solate from the Solomon Islands collecting data from one of the villages. So this is a map of the 18 villages that we recruited from. A little bit on the methods. It was a cross-sectional survey of 18 villages in Western Province, conducted in 2019. We collected stool samples from a total of 830 participants. And then we used molecular diagnostics, primarily quantitative PCR for diagnosis, which allowed us to identify strongylitis. And the overall prevalence with any STH species was 63%. So 6 in 10 people were infected with at least one type of STH. And we do see some variability within villages as well. So you can see that, for example, for Nikeda americanus, that's a lot of villages was quite high prevalences, between 20 and 50%. And there's like one with low prevalence and a few with very, very high prevalence. And you see quite a similar pattern across the different species as well. And here I've just got the overall prevalence for each species. You can see that Nikeda americanus and Nikeda americanus is quite a big public health problem in these communities. But the two species that we're really interested in, Trichuris trichura and Strongylitis decoralis, overall prevalence is quite high for Trichuris, just over 20%. For Strongy, the overall prevalence wasn't as high, but we do see there is one village with a really high prevalence of between 20 and 50%. So I think these findings really highlight the need for ivermectin-based PC to control these two species. Just really quickly, also spent a bit of time doing a risk factors analysis for this paper as well. So we're looking at various water, sanitation, and hygiene, known as WASH, and environmental variables, looking at how well they predict STH infection, given that we know that WASH variables and environmental variables are associated with STH infections. We found a few significant things, such as only household latrine was protective against Nikeda americanus infections. But we didn't find as much as we were expecting. And I think this might be due to homogeneously poor WASH access in the study villages, where over 90% of the sample reported practicing open defecation, meaning that naturally we'll see very limited variation in the data. All right, so next paper. So that was the baseline paper in the Solomon Islands. This was conducted in the same setting, the study. It's a follow-up study of the previous paper, and it really aims to evaluate the long-term effectiveness of ivermectin MDA in reducing burden of STHs, in the context of the scabies MDA program. And this paper was recently published, actually. I think it got published last week in Lancet Regional Health. And this is us conducting, this is Susie Lake from Murdoch Children's Research Institute leading the scabies component. This is me, and this is our really lovely fieldwork team that was doing the training. And this is our fieldwork team on the right as well. So, as I said, a scabies cluster randomized trial was being run by the Murdoch Children's Research Institute, our colleagues. So we saw it as a good opportunity to add STHs on as a secondary outcome. Now, because ivermectin is used widely for several NTDs, like I've mentioned, that these diseases are often co-endemic in the same setting, we saw that it was an important opportunity to generate evidence documenting the secondary effects of these interventions on off-target conditions. In this case, those off-target conditions were STHs. This is the same map as before, showing the 20 villages, and we had a 21-month follow-up to assess the effectiveness of ivermectin. And these are the results. So this is for the first species of interest, Trichuris trichura. In the left columns here, I have the single dose ivermectin arms. It's just using a single dose of ivermectin implemented in an MDA program for scabies. And here we have 2 doses of ivermectin. And this trial was set up to test the difference between these two for scabies. But because we're looking at STHs, we're not too concerned about the difference between the arms. We're more interested in the differences within the arms. So for Trichuris, our findings suggest that ivermectin MDA can sustain impact on Trichuris prevalence for 21 months. So you can see in the single dose arm, the prevalence reduces from about 20% to 11%, a significant reduction, and a very similar pattern observed for the double dose arm as well. However, given that we failed to detect difference between the dosage arms, there seems to be no difference in the magnitude of effectiveness between single and double dose ivermectin, at least not at 21 months for Trichuris. But what is really promising here is that we do see an impact of ivermectin against Trichuris, a species which has quite low efficacy with ivermectin, with albendazole, sorry. So this is the second species of interest. This is Strongylitis stercoralis. Again, single dose arm here and double dose arm here. Again, we see a very similar pattern to Trichuris. We see a significant reduction in each arm individually, but no differences between arms. And this is not too surprising. Ivermectin monotherapy is known to be highly potent in clearing strongy infections based on some clinical trial evidence. But at least right now, it's still unclear whether two doses and is better than one. If there was a difference between arms, I suspect that we didn't detect it due to power issues. You can see here that the baseline prevalence was quite low to begin with. So I think therefore it would be very interesting to see if there would be a difference in settings with a higher baseline burden. But again, the important takeaway from here is that albendazole, we know from the past literature that albendazole doesn't work for this species. Ivermectin seems to be working pretty well, which is really great news. Here I have one of the hookworm species, Niceta americanus. We don't see any differences here, and this is not surprising at all. We know already that albendazole works very well for the species, and because the study was looking at ivermectin only, we weren't expecting to see any differences. But in this setting, hookworm is obviously a really major public health problem in these study villages. So there needs to be albendazole PC delivered to control the species. And this is another type of hookworm species. This is Encelostomum selanicum. And again, this is not surprising. It follows a similar pattern as the hookworm findings. And we know that ivermectin doesn't work well for the species to begin with, so we weren't surprised here. Alrighty. So that brings me to my fourth and final study. Hope everyone is still with me. So that was Solomon Islands. I want to travel 4,000 kilometers west to Timor-Leste and talk about the long-term impact of MDA using ivermectin and albendazole in reducing both STHs and scabies. Most of the research I have presented just now was on ivermectin alone in the Solomon Islands. Now I'm interested in looking at ivermectin and albendazole in Timor-Leste on both STH and scabies. And this was really a fun study to run. This one was published in the Lancet Global Health just in June 2023. And here we have pictures of this is Salvador Amaral, really fantastic local infield project coordinator, teaching children how to provide stool samples for the STH component of the study. And these are some clinicians at the schools conducting clinical skin examinations to diagnose scabies infections. This was a really fantastic team to work with. Study setting, so you can see here in Timor-Leste, we had 6 schools spread across 3 municipalities. We had one urban municipality, Dili, which is the capital city of Timor-Leste, and we have 2 rural municipalities, Amera and Manifahi. Now, this was an observational before and after study, and this is a schematic of the study timeline. So the Timor-Leste Ministry of Health commenced a plan for national lymphatic filariasis and STH control in late 2015, which included 2 drugs, the alpha-carbamazine citrate and albendazole, so the D and A components of IDA. And more recently, it was in 2019 that they decided to include ivermectin to accelerate the elimination of lymphatic filariasis. So that resulted in them implementing a mass drug administration program using 3 drugs, ivermectin, DC, and albendazole. And it's important to note that it's a single dose of each of these drugs. You can see here that we completed a cross-sectional survey immediately prior to the MDA. The Ministry of Health implemented the MDA, and then 18 months later, we came back and repeated the assessment to assess the impact of this intervention on scabies and STHs at 18 months. So these are the Timor-Leste scabies findings. On the left, we have scabies, baseline and follow-up. On the right, we have impetigo, which is the superficial bacterial skin infection, baseline follow-up. Now, I just want to say a few words on this first. So you can see here that the scabies prevalence reaches from 37% to 13%. This corresponded to a relative prevalence reduction of 62%, and so it's significant, as you can see here. And for impetigo, we observed a similar pattern. The relative reduction you calculated ended up being 86%, and I think I have that over here. Yes, I do. Now, it's important to note that there was a cluster randomized trial in Fiji a few years back called the SHIFT trial, led by Lucia Romani and colleagues. Lucia's works at the Kirby Institute as well, found that double dose of ivermectin MDA led to an 89% relative reduction after 2 years. Here we found that single dose ivermectin MDA led to a 62% relative reduction after 18 months. So we found that single dose delivered in the context of an LF elimination program resulted in a 62% reduction, which is quite a substantial reduction considering it is single dose. And these are quite important findings considering that it was previously believed that we need 2 doses of ivermectin to treat and therefore control scabies. There was another study led by Andrew Steer from Murdoch that published a cluster randomized trial on it in the Solomon Islands. This study was the first to really investigate this hypothesis of how effective is single-dose ivermectin MDA outside of a strictly controlled clinical trial context. And we found very, very promising findings, as you can see here. Okay, so that's the scabies and impetigo findings. Sort of want to talk about STHs now as well. So the middle column and the right column are our species of interest. These are the ones that don't respond well to albendazole. And you can see that, there was a significant reduction in trichuris prevalence here. So we went from 4.8% to 0.64%. It's quite a low baseline prevalence to begin with, but it was a statistically significant reduction. This corresponded to an 84% relative reduction. And for strongylitis, based on previous research demonstrating the impact of ivermectin monotherapy on strongy, we were expecting a significant reduction here, but unfortunately, we're just unable to observe any due to lack of power. You can see here that we had a very low baseline prevalence, resulting in flooring effects. There's only so much that you can decrease from 1%. And for Ascaris, we did not detect an impact here. We do know that albendazole works quite well for this species, and this MDA program did include albendazole. But we suspect it was because of the delayed follow-up time. So for this study, we're actually meant to do a 12-month follow-up, but because of COVID, we ended up postponing it to 18 months. So we do observe, a decreasing trend, not statistically significant, but I suspect that there was a reduction and that the reduction was nullified due to rapid reinfection known to be associated with that species. And these are just various types of hookworms. Again, we didn't see any differences here. And I think probably due to reinfection and the extended follow-up period. All right, so these are the final set of results. So with STHs, we measure infection intensity using a metric called the mean eggs per gram stool. And it's thought that this is meant to be a proxy of clinical morbidity. So I'll just acclimate you to this table. The first column, we have different species of STHs. In this column here, we have the mean EPG, eggs per gram stool, at baseline, and then the mean EPG at follow-up, and then the incidence rate ratio is a metric of relative difference from baseline to follow-up, and then the p-value for the incidence rate ratio. And the important thing to take away here is that we do observe a significant reduction in infection intensity and therefore clinical morbidity in these 3 species, even if we don't observe difference in prevalence. I found that quite interesting. And this suggests that morbidity was improved for these 3 species even after 18 months, which is quite a promising result. All right, so that brings me to the end. So a few recommendations. I've presented a lot of findings and there's a lot of numbers thrown around, but I don't want to get lost in the weeds too much. I think the main takeaway from this is fairly simple, is that ivermectin should be added to STH control programs. The crux of the matter is that albendazole doesn't work well for trichuris, nor strongy, and ivermectin, either used alone or in combination with albendazole, can really fulfill this gap. So therefore, it should be added to STH control programs in settings where trichuris and strongy are endemic. The second part is about scabies. So I talked a little bit about the differences between 2 doses of ivermectin MDA for scabies versus 1 dose. And my study in Timor-Leste investigated that hypothesis in a programmatic setting. Now, although we did find promising findings in that Timor-Leste study, there just isn't enough findings and data right now to really make any firm conclusions. So that's why I've written here that 1 dose of ivermectin MDA for scabies should be further investigated in different countries, in different population, different settings, just to form a really robust evidence base that can be used to inform WHO guidelines, hopefully sometime in the future, to use a single dose of ivermectin MDA to control scabies. The third recommendation, now I didn't talk about PCR too much, but it was an important aspect of my studies. We use PCR for diagnosis for all of my studies. For STHs, the WHO recommends using microscopy. There's a few limitations on microscopy, which I won't get into right now, but effectively, PCR allows us to diagnose and therefore identify strongylitis infections, which microscopy cannot do. So I do believe that qPCR should be considered in STH diagnostics to enable a detailed characterization of STH burden, defining the public health need for ivermectin and therefore implementing ivermectin MDA. Those are the 3 recommendations. Future directions. I find it quite interesting when I was writing my PhD thesis that I had a lot more questions than answers after completing all the studies. And there's a few areas of future directions that I think would be worthwhile for future research to pursue. The first, one of the most glaring, I guess, limitations of ivermectin is that it's contraindicated in these 2 risk groups, young children and pregnant women. We know young children and pregnant women are at very high risk of morbidity, especially with hookworm infections. So in MDA programs that use ivermectin, they're not given to young children and pregnant women. So I do think we need more research investigating the safety of ivermectin in these 2 risk groups. As I said earlier, there was some observational evidence suggesting that certain dosage levels ivermectin might be safe in young children. There are ongoing clinical trials to test this hypothesis, but this is definitely a very important avenue for future research. So the second more obvious limitation of ivermectin that often gets criticized for is that ivermectin has been rolled out large scale, delivered to millions of people for the last 30 years in MDA programs for onchocerciasis and lymphatic filariasis. And this raises the question of drug resistance. If you roll out ivermectin at this scale over such a long period of time, do you run the risk of developing drug resistance? And there isn't too much compelling evidence that drug resistance to ivermectin has occurred in humans just yet, but it is a phenomenon that has occurred in livestock. So because of that, it's very important in parallel to be investigating alternative therapeutic regimens for effective NTD control. And moxidectin is really the new superstar now in the NTD world. It's a macrocyclic lactone-based drug, and based on some early clinical trial evidence, the evidence suggests that it may play a very similar role to ivermectin in controlling NTDs. I think it was designed and indicated for onchocerciasis. There's some preclinical studies in pigs that shows that it's effective in treating scabies in pigs. And there's a few human studies conducted by Jennifer Kaiser's group in the Swiss School of Tropical Medicine and Public Health in Basel, Switzerland. They're running a lot of interesting phase 2 and 3 clinical trials showing that moxidectin is quite effective for trichuris and strongylitis. So I think this is really a hot new future direction to go down. And then the final thing, I didn't touch too much on this, the complementary role of WASH. WASH stands for water, sanitation, and hygiene. It's very important to improve access to these type of facilities to prevent initial exposure to the parasites in the first place. Okay, so that's it. I'd like to acknowledge all of my colleagues from the Solomon Islands and Timor-Leste. This was really fantastic collaborative effort. It wouldn't have been possible without them. And I'd also like to thank the Global Health Program as well as my PhD supervisors. And it was a real pleasure working with them for the last 3.5 years. And this PhD would not have been possible without the valuable support of Suzanne, John, and Naomi. That is it. I'll take any comments and questions you have.
Thanks, Brendan, for a really nice presentation, and as well as introduction to the NTD world, and besides your work and your important findings. We welcome any questions you may have for Brendan. Alison has a question, so I'll read it out loud. Great presentation, Brendan. Did you have any feedback from communities, health workers about adding ivermectin to treatment regimens?
Sorry, can you repeat that question again, Susanna? I didn't
If you have any feedback from communities or health workers about adding ivermectin to treatment regimens.
Not that I can recall from community health workers. Our colleague Marita Montero from Timor-Leste, who works in Timor-Leste Ministry of Health now, did a really terrific effort of advocating for the use of ivermectin in the 2019 MDA program, which we evaluated. And that was before I had started. And I understand that was a lot of effort from her and a lot of work, advocacy work to get that sorted. But no community feedback as far as I'm aware of. I don't know, Susanna, if you have any.
Yeah, I can add some to that. Yeah, so that's a great point, Alison. So IDA, or this triple drug therapy, is now being advocated for LF, lymphatic filariasis elimination, in some settings. And there has been, not in Timor, but in other countries, where the triple drug therapy, as opposed to the double drug therapy, has been advocated. There's been some interesting acceptability studies, and in general, the addition of a third drug doesn't seem to bother people that much. What seems to bother people is the fact that in some settings, not for LF, because you do it for 5 years and you're supposed to stop if you're effective, but for onchocerciasis, you may have to do it for decades. So we didn't look into this in Timor, but we are looking into that in Vanuatu, where we are also doing another triple drug therapy for other NTDs. And the sort of preliminary findings that we have been having access to actually says that people prefer to get all the drugs at the same time instead of having multiple visits to be given different drugs individually. But we'll be looking more into that as well. Okay, a question from John. Great work, Brendan. It has been a pleasure to work with you on these issues and important projects. I had to leave your excellent talk for a minute. Did you have a chance to mention the gap in ivermectin donations for STH and scabies?
Yes, thanks, John. Great to hear from you again. That's a really good point. So currently, ivermectin is being donated by multinational biopharmaceutical organizations to the WHO. However, it is currently only designated for specific diseases and specific risk groups. So we know that it's donated for onchocerciasis, and we know it's donated for lymphatic filariasis. But currently, there is a gap in the donations for SCHs directly. So that's an important avenue of future research to be doing as well. And I really hope that my findings and our findings add to the evidence base that supports the recommendation to add additional donations of ivermectin specifically for STH control, because I think it's very important to do that, specifically in settings where Trichuris and strongy are endemic.
Thanks. Yes. I don't see any more questions in the chat, so I'll give people a few more seconds if there's any other comments or questions for Brendan. Okay, otherwise, I guess it's my pleasure again to have had you. Well, thanks for joining us again from your new position and presenting to the Kirby Institute your findings from your PhD. Good luck, and we'll see each other again soon.
Sounds good. Thanks, Susanna. It was a real pleasure working with you for the last 3.5 years. Thanks everyone for tuning in today.
Thanks. Bye.
Okay. Thanks, guys. Bye.